I do. I've been paying workout plans all semester. Finish that. My black friend.
Okay. All right, we are moving along in the semester here, and so we've got exam 1 coming up in a couple weeks, and so going to be working to get your brains ready for that. I think in addition to that, let's see. Oh, one of the things also, somebody had pointed out that I had the second exam scheduled on April 5th, so that's been corrected. April 5th was a Friday, and it will be on a Thursday. So thanks for that, noticing that. Other than that, I guess I also, again, I think I showed you guys that spreadsheet that you could start filling in, right, on nutrients. Yep. And so I still encourage you to start using that format to sort of give you a study tool, and use the slides, use the book, use that Linus Pauling Institute website. I think all of those tools can help you put those elements together. So any questions about anything before we move along? Okay. I lost my usual glasses that are good for all distances, so I'm going to be doing a whole lot of this today. But old eyeballs, not fun, but I'll tell you. Okay. What I want to do today is kind of a mixed bag of things. Let's jump back into the slides for a bit, and then I want to throw some questions at you too, to give you a sense for the kind of things to expect on the first exam. So we left off last time talking about vitamin C function, and one of the key things that it does, of course, is this what we call post-translational hydroxylation, and that's, some of you missed that quiz question because it indicated that they were hydroxylated before they went into the protein, and in this case, it's after it goes into the protein. And later on in the course, when we get into the minerals, we'll talk about an interesting amino acid. Normally, cysteine has sulfur in it, right? Cysteine and methionine are both sulfur-containing amino acids. Well, there's a selenium, selenocysteine also. And that one actually does get incorporated as is into a protein. So it's not a post-translational thing like this. So, okay, let's move along here. My pointer will start clicking for me. Let's see. Oh, yeah, you got to put in there. Ooh, good volume. Okay, so other things to think about. We talked about tyrosine metabolism. I think, on this, it's really just, I don't expect you to try to get down all these compounds that it's broken down into, but just to know that that vitamin C, copper, and iron, that these all three play a role. Of course, in this part of the course, we're not focusing on minerals so much, but I still throw that in because we'll be thinking a lot about things like copper and iron later on in the course, during the second half of the course. And all of these things work together. So I think rather than get too caught up in all of these intermediates with names of things we don't talk about a whole lot, focus on the nutrients that are driving things. So, the ascorbate is involved in there, iron, copper, all of these things working together. This is just showing another reaction with vitamin C, and we sort of talked about this one. I think where to focus here. This is not a function of vitamin C that we focus on a whole lot, so this is not the kind of thing that I would probably have a specific question about for the exam purposes and stuff, although, the one thing that's important to realize is that it can play a role in neurotransmitter synthesis. And in that case, then you can relate vitamin C deficiency to symptoms that are not only just collagen-related symptoms, but also possibly brain function and or other neurological problems. So this just summarizes some of the things that vitamin C is involved in. And I think when you go through this kind of a list of things, think about, key functions of it. A lot of this is antioxidant function, and vitamin C can also have that pro-oxidant activity too, which we only touched on a little bit, but certainly can have some links with certain disease risk factors. And let's see, moving along here. This is a breakdown of vitamin C. So let's say you're taking megadoses. What's going to happen to it? Some of it's just going to be excreted, but I think the key thing that you want to focus on in here, the breaking down to xylose is interesting just because that's a sugar that can be metabolized. But oxalic acid over here is the important one, I think, to think about, because when you have somebody who's been doing megadoses of vitamin C and they get kidney stones, then you want to step back and say, hey, you need to back off on the vitamin C, possibly on some high oxalate foods in the diet, things like spinach and even taro leaf is high oxalate, and rhubarb. Everybody has rhubarb all the time, right? Yeah, right. But anyway, that's, I think, one of the key nutritional things to think about when we start talking about the problems with getting too much. So I just touched on this xylose stuff, not all that important. And antioxidant oxidation reduction capacity for ascorbic acid, dehydroascorbic acid. Just two ways of looking at the molecules here. And basically, it's losing and gaining hydrogen ions. And so you can see where they're coming from. On oxidation, it's losing 2 hydrogens. On returning dehydroascorbic acid back to ascorbic acid, it's picking up 2 hydrogen ions. And then we talked quite a bit about the common forms of vitamin C. We said this one is the one bound to a fatty acid. And just another illustration of it here on the right. What would you call the one bottom left? Sodium ascorbate, right? And And the one on the right, yeah, calcium ascorbate, got calcium in there, right? So pretty straightforward. These are forms that you may see in dietary supplements at times. Ester C, we talked about this enough already. And a couple other forms. Scurvy. Scurvy is so interesting. And so things that typically are symptomatic of serious vitamin C deficiency are related to collagen. Hemorrhagic signs. Hemorrhagic mean easy bleeding, blood vessels break easily because the structure is compromised. And hyperkeratosis of hair follicles, that means you're getting the skin around that is sort of growing abnormally and getting kind of lumpy typically. And then the hypochondriasis is getting at the psychological manifestations. So remember we talked about neurotransmitter synthesis being affected, and and then hematologic abnormalities, so on. So you can see even scurvy is treated with 100 to 300 milligrams per day of vitamin C typically. When you go to the drugstore or the health food store to buy vitamin C pills, what are the typical dosages? 500, right? What do you say?
You're going to say 500 to 1,000?
Yeah, 1,000 is not unusual. Yeah. Yeah. In fact, I was trying to find one that was like around 250 and I couldn't find one that low. But I think you can if you look at longs and stuff, but it's easier to find those really high megadose ones, which, as we saw with the renal threshold stuff and everything, most of that's just going to be going out in the urine and potentially causing kidney stones. And we said, most animals synthesize vitamin C. Guinea pigs don't. And and then we talked about the pirate thing, all the English limey guys. And did I talk about, I don't remember if I talked about the common bird here in Hawaii that does not synthesize vitamin C. It requires that. Which one was that? That'd be good. There's one that eats papayas, right? That'd be a good extra credit question. What bird is that? Yeah, remember the red-vented bulbul. And red-vented means they got a sort of a red splotch right under their tail feathers. They're kind of where their butt comes out. So their vent is red. So you could say, but they got to have their vitamin C just like us. Recommended intakes in the milligram per day range. Smokers need a bit more. And high dose is probably not a good idea for some people, especially with the genetic conditions of hemochromatosis, possibly the thalassemias, and so on. Looking at status, we generally just look at plasma concentration. So I wanted to go over this renal threshold stuff once more too, though, because it might have gone by you kind of quickly. And it shows you some concepts that are pretty, that apply to a lot of things. So the first curve here is showing you blood glucose. And so if we consume glucose at time 0 here, what happens to it? And so we look at the normal person, the solid line there, it goes up, of course, and by about somewhere around 2 hours, depending on the amount of glucose consumed, it'll come down to starting resting levels. So insulin, of course, goes up, which affects that coming down. In somebody who's got diabetes and they're not very insulin sensitive, then it's going to go, the dotted line shows you, or the dashed line shows you that it goes much higher, stays up a bit longer, maybe not a whole lot longer, but actually this curve maybe should be more like this. But because the insulin is not working as well. But the key thing is, goes up in the blood, and then in the case of the diabetic, it's exceeding this renal threshold here. And so some of that glucose is going to show up in the urine. Because the kidneys can only reabsorb so much glucose, and so that's why in diabetes you see some glucose going out in the urine. That's why an uncontrolled diabetic has a lot of extra urine flow. They call it polydipsia and polyuria. Polydipsia meaning thirsty, drinking all the time, and polyuria means frequent urination, lots of urine production. So that sort of makes sense. When we look at vitamin C here, you can see that the vitamin C going out in the urine on the y-axis over here, very little goes out up to, and this is looking at the plasma concentrations, which are of course dependent on what you've taken in. But if you take in enough so that your plasma concentration exceeds about this 1.6 here, then you start to see it going up in the urine. You've exceeded the renal threshold for vitamin C. Kidneys can only reabsorb so much. And so it just goes out in the urine. Another way of looking at that over here is oral intake in terms of vitamin C milligrams per day here. And you can see that once you get up above around 60, 65, somewhere in here, that oral intake of vitamin C at that level brings the plasma levels up to that point where it exceeds the renal threshold, and you see your urine vitamin C going up. Now, you see this with most water-soluble substances, most water-soluble vitamins and things like that. So it's a good concept to understand. Any questions there? Okay. And then this is just, of course, another way of looking at this too, where we have, again, the dose, down here at about 100 milligrams per day. You're getting pretty close to that renal threshold. And so what you're looking at here with the plasma ascorbic acid plateauing, certainly above 500 milligrams dose, what you're looking at is a combination of less absorbed and more going out in the urine. So your body's trying to keep the blood levels from getting beyond a certain point. And it can do that only two ways in this case. Well, maybe a little bit of three ways, but mainly two ways. One is reducing absorption, the other increasing excretion, and then the third would be possibly increased catabolism of vitamin C, as you can break it down, but that's not the main route usually. So, okay, any questions? Yeah.
When people are deficient, does the renal threshold stay the same then?
Oh, yeah, good question. When people are deficient, would your renal threshold stay the same? I don't know for sure, but I would think it probably is going to stay pretty much the same. Where you typically see change on these kind of things more is on the percent absorbed. Yeah, so you're probably going to absorb more, but the percent excreted is probably going to stay about the same because kidney function doesn't change too much.
So if you give people like 500 and they're deficient, they would only be able to stay with about 100 and lower range.
Probably, yeah, and that's why, on that one slide earlier, it said, that typically is 100 to 300 milligrams per day to treat scurvy. And probably because they found anything much above that, it's just going to be going out anyway. And, and so, yeah, I would think it would be mainly on the absorption side, and you're pretty efficient at absorbing it when you're deficient. Yeah. So, okay, any other questions? Okay. Let's see. And this you can take some time on your own too. I think this is just a good summary of all what we've talked about. And antioxidant function with the details on the protons and electrons in terms of vitamin C functioning and the iron and copper relationship. So let's see, norepinephrine synthesis. Food sources, I think those are pretty straightforward. So, okay, any last questions on vitamin C before we move along? Okay, well, let's take a little break and let me start throwing some questions at you guys. See how your brains are working. If we talking about B vitamins, and what B vitamin would you think might not, the status of it would not be adequate if a person had a low protein diet? Well, B12 is not a bad thought. Just if it's animal protein is too low, then B12 could be an issue. But yeah, I was thinking more niacin, because if your tryptophan is low because your total protein is low, then you can't synthesize niacin. And so your dietary requirement for niacin, preformed niacin, would go up. Yeah. And yeah, basically it was getting at if the diet gets too low in protein, what vitamin do you think that would have an effect on? And the concept there is that if it's low in protein, then it's going to be low in tryptophan too. Tryptophan is one of the amino acids that tends to be in the shortest supply in most proteins, and so you wouldn't have as much to synthesize niacin. So if you have somebody with a high protein intake, just the opposite, their niacin requirement is lower because they have more tryptophan to be converted into niacin in the body. But it seems like, I suppose there is probably a dose of tryptophan that would meet your niacin needs. I'm not sure what that would be. I think with most normal diets, you always have some niacin requirement. And the things like the RDAs are based on sort of the typical protein intake and the typical dietary intake of tryptophan. Okay. So, is there one vitamin deficiency that you think of in relation to people with chronic alcoholism? It's, serious alcoholism is known to affect brain function, among other things, but it also messes up the intestinal lining if it gets bad enough. But thiamine, thiamine is actually the one that we often look for in alcoholics. And they'll have symptoms somewhat like beriberi. So you don't see beriberi much these days. People don't have that weird of diets, but the reason alcoholics sometimes can develop that is because if you figure, a serious alcoholic, half of their calories can be coming from alcohol. So that doesn't leave a whole lot of food to provide nutrients. And so even something that we normally get plenty of can start running low. And it's a combination of the damage to the intestinal tract too. If I said CoA, what vitamin do you think of? B5, also known as the P vitamin. It's one of them. Pantothenic acid, right? Pantothenic acid, pantothenate is the dissociated form. I said TPP, what vitamin do you think about?
TDP?
TPP, yeah. TPP would be something pyrophosphate. How about PLP? B6, right? Yeah. How about FAD? Riboflavin, yes, said in a nice chorus. Yes. And NAD, what do you think of? Niacin, yeah. So then back to TPP, I don't think. Thiamine, right? Thiamine pyrophosphate, right? TPP. That's a common active form of it. Yeah. And active forms of vitamin A. What's the first thing that comes to mind? Actual active vitamin A, not. That's a precursor to vitamin A, beta carotene, right? Retinol, yeah. What are other forms of vitamin A? Retinol, retinoic acid, right? Yeah. So all forms of vitamin A. And let's see. This is an easy one, I think. Vitamin most likely to be deficient in a vegan diet. B12, also known as cobalamin, right? Do you remember we talked about vitamin B12 deficiency and what we use to diagnose it? There's a reaction, chemical reaction that's dependent on B12, and so what's that? Close. It's what? Yeah, you guys got part of it. It's methylmalonic acid. Yeah, and we'll go back over that step in metabolism probably in our review too. So what about folate? We have just folic acid form, and we have these polyglutamate forms, and just formed in naturally present in foods. Which form is absorbed the most efficiently? or the highest percentage absorbed. Right, the synthetic folic acid in supplements or fortified foods actually is the one that's absorbed most efficiently. Let's see. We touched a little bit on a vitamin that is recommended for breastfed infants. Got infants that's exclusively breastfed. Particular vitamin that yeah, well, iron is recommended, but not a vitamin, right? Yeah. So vitamin what?
Okay.
Vitamin K is actually a good guess too. That's usually injected though at birth.
Vitamin D.
But someone, yeah, vitamin D is in dog, yeah, and because it doesn't seem to be carried in mother's milk that much, and most of the time, you know, don't have your baby sunbathing a lot. Probably a good idea too. So better to have the vitamin D just in the supplement form. Usually it's just in a liquid form. When we think about vitamin A requirements, you know, remember vitamin A comes in, we just talked about retinol and retinal and all that stuff, and then it comes, as you mentioned, beta carotene too, as a form. So when we talk about how much vitamin A is in a food, what are the units of measure that we use? Remember what those were called? AEs, which stand for retinol, activity, equivalence, right? Like pulling teeth, but I got it. Yeah, retinol activity equivalence. And that's the units of measure. And the reason that sort of thing is used because, you know, it's equal to 1 microgram of retinol. But if you want to say, okay, well, how much beta carotene do you need to be equal to 1 microgram of retinol, then that's going to be 12 micrograms of beta carotene. And so that's the trend anyway. Now on you know, food and supplement labels, you'll see it in international units too, that which we're trying to kind of get rid of. Not happening too fast. Okay. Problems with too much vitamin A? What comes to mind? Remember what teratogenic means? Teratogenic effects of excess vitamin A means increases the risk of birth defects for women taking excess amounts during pregnancy. And that's probably the scariest thing. There's bone problems too that can develop over time, and even liver problems potentially. Let's see. If I asked you, what forms of vitamin D are there? There's the easy answer is what? D2 and D3, right? Yeah, good. And So D2 is also known as ergocalciferol, right? Yeah. And D3 is cholecalciferol. Yeah, a bit of a tongue twister. And it comes from a form of cholesterol, of course. And so if I ask you what form is in salmon and milk, D3, right? And in mushrooms, D2. Yeah. Where would you expect most of the body's vitamin E to end up? It's fat soluble, right? So extra vitamin E is going to be in the fat stores, right? Adipose tissue. So, okay, well, good break from the slides, but let's get back into the slides. Throwing questions to you guys off and on. Okay. It's good to remember too that some of these key nutrients that we add to enriched grains, thiamine is one of those, and that was done years ago for good reason. It was an easy way to make sure people got enough of it. And just in 3 different forms. In animal foods is TDP or TPP, and then must be phosphorylated to be absorbed as free thiamine, and absorption is usually pretty good. Okay, let's see. There are thiaminases in raw fish that probably aren't of that much concern unless that's all you were eating. And these also tannic and chlorogenic acids and things, caffeic acids. Tannic acids are in things like tea and red wines and grape juice, dark grape juice. Chlorogenic and caffeic acids are in coffee. Again, under most conditions, nothing that you would be concerned about in the amounts commonly consumed, but they can inhibit thiamine absorption when consumed at the same time. And we already talked about the ethanol business. Interferes with absorption, increases requirement actually a little bit too, because of the pathways for metabolizing ethanol. And so on. So stop me if you have questions. I think we've talked a fair amount about its role in energy metabolism, a little bit about synthesis of pentose sugars and nicotinamide, NADPH anyway, and its role in membrane and nerve conduction, so non-coenzyme capacity. So let's see. Milligram range, berry, obviously, you know that, and toxicity, we have no upper limit for this one, haven't seen a toxicity effect. Everything has the potential for toxicity, but we don't know what the toxic intake would be for thiamine. That's what it looks like in the free thiamine form versus the thiamine TPP or thiamine pyrophosphate form. And this is just a summary of the criteria that's used for setting the, in this case, EARs and RDAs. So you can see that in the case of, go with adults down here, 18 to 70-year-olds, it's about 1 milligram per day for the EAR, a little bit less for women just because of average body size being a little smaller. And and then the RDA is increased to 2 standard deviations above the EAR, which comes out to 1.2 for men, 1.1 for women. Pregnancy increases it a bit, and as does lactation. So you can see that goes up 1.4 in both of those cases. Because of the key things, obviously, it's the different intake levels for younger age groups, mainly just due to body size differences. You can see, though, that the requirement for it's kind of interesting that you see this little blip in the teenage female being a little higher than the adult female for the EAR, although that didn't translate into a higher RDA. I'm not sure what the thinking was there. Maybe it was just statistical. So, okay, I mean, those are the ways I want you to sort of start thinking about these RDAs, though. Think about how they're designed. You know, you got to have an estimated average requirement. You know, and we talked about this early in the course, how you then set it 2 standard deviations above that average to take into account just about everybody in the population. Common food sources. So, you know, if you think about, okay, it's about 1 milligram per day you need. You can see with these foods here, which ones are pretty good sources and which ones are not. Does not have enriched white flour on there, which I probably should have had, but I just borrowed this from somebody else. Thiamine-dependent enzymes, the TPP specifically, you can see there's this transketolase enzyme, and it's involved in metabolism of pentose phosphate molecules up here. And then we talked a lot about this pyruvate dehydrogenase complex. Thiamine's playing a role there. And then this reaction down here is somewhat similar to where thiamine's playing a role in metabolizing alpha-ketoglutarate. So in energy metabolism, when we say that thiamine is involved in energy metabolism, well, this is obviously pathways for energy metabolism, metabolizing pyruvate to acetyl-CoA and alpha-ketoglutarate in its role throughout the citric acid cycle. So, okay, any questions there? All right. So causes of inadequate intake, of deficiency, inadequate intake, of course, defects in absorption, alcoholism, interesting HIV and AIDS, gastrointestinal liver diseases. Interesting, defective parenteral nutrition is one of those things where somebody messed up and mixed up the tube feeding, in this case IV feeding solution without thiamine, and then the person gets beriberi, and you've got a case study on your hands, which is not good. Drug interactions, some drugs can interact with thiamine. Anorexia nervosa tends to cause a lot of things to be deficient. Thiamine, certainly one possibility or one likelihood because of very little food intake. Signs of thiamine deficiency, peripheral neuropathy, calf muscle tenderness, what's called wet beriberi. You see edema develop. What's edema? It's accumulation of fluids interstitially, right? Around, you get basically some swelling in your tissues. Blood vessels can't take up fluid efficiently. And that can lead to heart problems, tachycardia, meaning rapid heart rate, and congestive heart failure. And infantile beriberi, that can be real serious because it can affect brain development, among other problems. And so that is one of those that can occur in breastfed infants if the mother's deficient. So, in Western societies, generally that's not an issue. But in some countries where, there's really borderline nutrition problems, you can see the woman, if the mother doesn't have enough thiamine in the diet, then the baby's not going to either, if they're breastfeeding. And, that's why in some of these places too, a lot of these aid groups will try to offer infant formulas to supplement the breastfeeding. And it's a real political kind of balancing act thing because, ideally we want to promote healthy breastfeeding, not just selling Nestle's infant formulas, right? However, if we've got a condition where the breast milk is deficient because the woman is in a situation where she's not getting adequate nutrition, then there's a good argument for donating that infant formula and supplementing the breastfeeding with some formula. It's one of those balancing act kind of things, but nothing is all good and all bad when it comes to that sort of stuff. So, have to be a little cognizant of what the conditions are going on and what's happening. Okay. Most common early on during breastfeeding, typically. And if the infant is thiamine deficient, they're not happy. It's and then the alcoholism, Wernicke-Korsakoff syndrome. Let's see, I'm going to skip through that for now. Riboflavin. So when you think about riboflavin, typically in most Western diets, milk is probably one of the richest sources of riboflavin. And so if somebody takes milk out of their diet, then you want to think about, okay, are they getting adequate riboflavin elsewhere? And you can, but sometimes people aren't doing it. And so we'll look at food sources too to see how you might do that. Riboflavin in foods destroyed by sunlight. That's why we've gotten away from putting it in clear glass bottles all that much, especially if it's going to sit out. And again, becomes as FAD, flavin adenine dinucleotide, or flavin mononucleotide, or riboflavin phosphate, and absorbed pretty efficiently, sodium independent carrier. And let's see, metabolism, what's important here, not too much maybe. And I think clearly you've got that FAD and electron transport chain playing a role. Also plays a role in vitamin B6 metabolism and choline metabolism or catabolism breakdown. And let's see, what else here? Obviously important in the pyruvate metabolism, succinate dehydrogenase, so energy metabolism, fatty acid beta oxidation is playing a role in. So it's all these things are energy metabolism related. So when people say, oh, it's involved in energy metabolism, well, you can see there's a whole bunch of steps there. In addition, I think the other thing we've mentioned was the synthesis of niacin from tryptophan, not tryptophan from niacin, which was that tricky question I had. And so it's required for that reaction and plays a role with glutathione and some of these other things. So this one, remember we talked about, okay, how do you know you took enough riboflavin in your vitamin supplement to, your pee is yellow, you know, kind of almost an orangey bright yellow. If it's enough, it almost looks like it's glowing. And so it's excreted readily in the urine and it's colored so we can see it. And you know, most things aren't that noticeable, but so it's a little educational tool that shows you what happens when you take more than your body really needs of something. And it just, if it's water soluble anyway. And this one also is needed in the sort of the low milligram range, 1.3, 1.1, goes up in pregnancy and lactation, as you might expect. The term ariboflavinosis is sometimes used for the state of riboflavin deficiency. Remember what angular stomatitis is? And yeah, going cracks in the corner of the mouth kind of thing. And cholosis, glossitis, those symptoms related to the tongue. Hyperemia, what's that? Huh? I'm not sure myself. I'd have to Google that one. Edema, everybody knows edema, right? And so low toxicity, no upper limit. Couple different ways of measuring status, which I wouldn't expect you to try to memorize all that stuff actually, but good to plunk into your spreadsheet if you're working on that spreadsheet. Just what the molecule looks like in the riboflavin part of the molecule, or the flavin mononucleotide or dinucleotide forms, and just the interconversion of the forms. What happens if it's exposed to light? It can be broken down to this lumichrome form that's no longer effective, or lumiflavin. Electron transport chain, B6 metabolism, we've kind of been through this, oxidative decarboxylation of pyruvate, or succinate dehydrogenase, all these energy metabolism forms, except for folate metabolism and niacin synthesis from tryptophan and so on. So mainly energy metabolism, but a couple other things thrown in there. Sources, a lot of foods, especially animal protein type foods, that tend to be rich in niacin, enriched grains, and of course we can synthesize some. And I think peanuts are a pretty good source, as I remember, things like that. pretty efficiently absorbed. Let's see. And let's see what's important here. I think probably don't need to get all caught up in the forms that are excreted, but just that NAD, NADP are the active forms, and they do break down and get excreted in this methylated and oxidized forms. Milligram need level requirements, and we consider 60 milligrams of tryptophan to be equivalent to 1 milligram niacin equivalent, ME for niacin equivalent. So right, any questions there? Okay. Pellagra, the 4Ds, those things always help. Remember that sort of stuff. Dermatitis, diarrhea, dementia, and death. You know, it's an essential nutrient. You can actually die from not getting an essential nutrient because something will come to a screeching halt eventually. That's dependent on that nutrient's function. Large doses, this is somewhat of clinical interest perhaps. I don't see this being done so much anymore, but been used to treat hypercholesterolemia, high blood cholesterol levels. And there's certain side effects. Certainly the high dose temporarily causes this vasodilation or flushing, tingling of the skin kind of a feeling, and it goes away fairly quickly. But if somebody's using that method to treating high cholesterol, typically physicians will want to measure blood liver enzyme levels periodically because it can damage the liver. So pellagra, we had this in the United States and Europe. We talked about, because they had gone to these heavy corn-based diets, and so a lot of the niacin was not bioavailable. How come the Mexicans weren't getting it then? Because their diet was heavy on corn, and they used this process to treat the corn, and with an alkaline solution. Usually they got it from like that wood ashes and things like that. You can probably use baking soda and stuff like that to do the same treatment. And I actually don't remember this video, but maybe it's worth going and taking a look at it. Video unavailable. Maybe that's why I don't remember it. I guess I better find a new link on that one. Okay. Well, let's go back to slides. But you might want to do a little YouTube search on that. I'm not going to do it right now, but forms of niacin, you can see why tryptophan can be a precursor. It's a fairly similar molecule to the nicotinic acid or nicotinamide forms. And so this is just showing the conversion of dietary tryptophan and nicotinic acid coming in. Both of them come in and become this essentially niacin mononucleotide here, and then proceed down the same pathway. And you get NAD, NADP. You can also get nicotinamide from the diet shown down at the bottom there. And all of that, all forms from tryptophan, nicotinic acid, or nicotinamide can give you the NAD, which can also then go to NADP. Food sources, you can see most of the, like I was saying, the animal protein foods are pretty good, including peanut butter, one of my favorites. And a lot of the plant foods, not so high, but they've all got it, certain amounts of it. So product 19, of course, is super high because it's fortified with it.
What is that?
That's a breakfast cereal. Yeah. Yeah, it's kind of like a total cereal, that kind of thing. I think it's Kellogg's version of, if I remember right. Yeah.
So if niacin is always just absorbed as niacin, right?
It can be absorbed. Let's see. Well, let's go back to that slide on that. We just was just a few slides back. Let's see. So we show it here. NAD and NADP can be in food, right? And then that's hydrolyzed to the free nicotinamide and then absorbed.
I just had seen something online that was like too high in NAD, the molecular use or something. I was like, isn't it broken down anyways?
Yeah.
You're still gonna build it in your body.
Right. Yeah. So yeah, on the surface that sounds cool, right? That's in the NAD form instead of just niacin.
Yeah.
But yeah, your body's going to break it down to either nicotinamide or nicotinic acid form of niacin. Yeah. And so that's what down here transported in mainly in those two forms, nicotinamide, nicotinic acid. And then you convert it back into NAD. So yeah, if you're consuming it as NAD or NADP, which generally you are in foods, you're going to break it down and then make it again. Yeah. Good question. Okay. Back to where we left off. Food sources. Okay. And then just another sort of look at niacin metabolism here. With the English spelling for tryptophan or tryptophane, I think they call it. And but that can all go to, you got niacin, nicotinamide, tryptophan, all can get you down to nicotinic acid, and then eventually the active form in the body is primarily going to be NAD or NADP, which is not shown here. And these PARPs, I'm not going to get into that now, but roles of niacin in energy metabolism. This is a pretty good little summary flow chart because it doesn't give you a whole lot of distraction stuff. It's just showing you the key spots in glycolysis and the citric acid cycle where NAD is playing a role. And so very, very important in both glycolysis and the metabolism of pyruvate to lactate and citric acid cycle. So, okay, any last questions on niacin? Okay. So pantothenic acid is one of those P vitamins, what we call it, right? B vitamins, starting with P, B5 in this case. I honestly, for things like pantothenic acid and biotin, I often forget what B vitamin it is because we don't use, for some reason, the B vitamin numbers for those too much. We should just call them by their names. But but pantothenic acid is also referred to as B5. And the other key B vitamin, which is B6, right? Yeah. Pyridoxine is B6. So generally, you hear very little about pantothenic acid just because it's pretty widespread in foods, and it's we're likely getting enough. And we talked about the pluses and minuses of the way things are listed here. So I won't go into that again. Key thing to remember for pantothenic acid is that it's a component of that CoA, so it plays a role in the pyruvate dehydrogenase reaction, especially. And and you know, this is what the ugly molecule looks like. The whole coenzyme A is there, and then the phosphopantotheniine. Nothing that you need to memorize or anything, but it shows you the part of it that is pantothenic acid here. And so that's the B vitamin form. So you can see that a number of things happen to it to get it into its active coenzyme form. And this is showing its role as an acyl carrier protein in fatty acid synthesis. And I think this is just showing this this molecule being, you know, this is the pantothenic component of this coenzyme A, and then down here separating from that to bind this apoprotein. Anyway, TMI maybe there. Adequate intake in the milligram per day range. Toxicity, again, no upper limit for that. And looking at literature, typically just blood concentrations or perhaps urinary concentrations. Okay, I think that's a good place to call it quits today. And I will probably get one more quiz up for you guys before the next exam, at least one. And then I may, I'm still thinking about an assignment I might want to give you too. So just to keep your brains working. All right, I'll see you next time.